Hello, everybody, and thanks for joining us today. My name is Jason Lotzar, and I'd like to welcome you all on behalf of Blue Cross Blue Shield North Dakota to the BlueAlliance Value-Based Care webinar for self-funded groups. For the agenda, we'll be discussing value-based care and the future of healthcare financing, the BlueAlliance background and progress, and finally, financing value-based care, and then we'll end with questions and answers. A few housekeeping items before we get started. Everybody will be on mute during the webinar, but you'll be able to ask questions at any time. So if you look at the GoToWebinar panel, you'll see a tab where you can type your questions, and at the end of the presentation, we'll answer as many as possible. Just a note, we'll only be answering questions related to the agenda topics we're covering today. So I'd like to introduce my fellow panelists who will be presenting today. Mike Carlson, the Director of Employer Consulting and Wellness Services, and Chelsea Matter, Director of Provider Engagement. Thanks again for joining us today and your continued trust. You can take it away from here, Mike.
Thank you, Jason. This is Mike Carlson, Director of Employer Consulting and Wellness at Blue Cross Blue Shield North Dakota, and we appreciate your time again today to talk about BlueAlliance, which is really how we're trying to change how we finance healthcare moving forward. As we all know, we've had a traditional fee-for-service model in which we're rewarding or paying for volume instead of value. So part of our BlueAlliance program is really trying to change this. And we've had a value-based program in place for over a decade, but BlueAlliance tries to align reimbursement with outcomes, making sure that our provider partners have the data they need to take care of our members and their employees and their family members. It's focused on healthcare, not sick care, and it's really an investment in practice transformation. So as I said, it's a fundamental change in healthcare financing. Really what we're trying to do is slow inflation and improve health outcomes. So it's really trying to bend the trend but improve quality of care. And to do this, we've invested in tools and data to make sure our providers have the information they need to take care of their patients, reward care coordination, but also asking providers to share the financial risk. And we're incentivizing providers to take on more accountability and risk over time. This helps us identify providers actively who are improving or can improve their care quality. And it really targets outcomes from a member basis and utilization of services. With that, I'll turn it over to Chelsea Matter, our Director of Provider Engagement.
Thank you, Mike. The journey to value has certainly been an interesting road. On the next couple of slides, we're going to show you the local and the national impact of that journey. Our value-based journey started in 2009, and we've learned a lot along the way. Working with the providers across the state of North Dakota, we've been able to build successful programs that meet the needs of North Dakotans. We're proud to say that BlueAlliance has been affecting care outcomes and cost. And so as we move into 2020, we continue to build on that success with the help of our provider community, with updated quality metrics and looking at how we can influence costs long-term. We have had fantastic participation amongst almost all of our primary care providers in our value-based programs, including BlueAlliance. As a result of their active engagement, we've seen improved quality scores overall across our book of business, but we've also experienced a 3.5% to 4.5% lower than expected cost trend, and that results in a $17 to $23 per attributed member per month average net savings. That net savings outperforms the national statistics that we've seen, and we're very excited about the work that we've been able to accomplish through the BlueAlliance program for everyone. One of the things that we use to measure success is whether or not our members are receiving more appropriate care. Nobody wants to be in the hospital, so we look at hospital admissions, and in particular, preventable hospital admissions. So things that could have been done maybe in a primary care setting that would have avoided that hospital admission. As a result of looking at this over the past couple of years and the value-based program incentives we have in place, we've experienced a 9% lower annual trend for preventable hospital admission rates. And from a utilization standpoint, that's about a 5.3% decrease in overall hospital admissions that would be considered preventable. So that's excellent. But we also see better care coordination as a result. And so one of the things that we ask providers to do as part of the BlueAlliance program is to engage in quality improvement projects. And so what are the things that they can do to improve care coordination? And there's been over 143 quality improvement projects in place across the state from providers of all sizes and geographic distribution, looking at how they can deliver care more effectively and at a higher quality. So excellent work being done by the providers to increase quality while holding down costs. We also work with providers to make sure there's more preventative care. One of the things that we know in looking at our data is that well child visits in North Dakota have lagged behind the national average. And so we worked with the provider community as well as some other statewide stakeholders to see if we could increase those rates, and we sure did. So more kiddos are getting into their primary care physician to have a well child visit. So a 25.8% increase is pretty amazing. We also look at breast cancer screening rates. This is something that as a state we do pretty well, but certainly want to see continued improvements in that space as well. So about 9% higher rate as we've been moving through BlueAlliance. Also, we look at preventable ER visits. So just like what we were talking about on the previous slide with preventable hospital admissions, we also look at preventable ER visits. And so we've also made some strides there, about 11.8% decrease in preventable emergency room visits, which is certainly excellent. This is all about access and making sure that folks can access their primary care provider when they need them, and that we can keep folks out of the ER, which certainly is a higher cost mode of accessing the healthcare system. So one of the great things about being a Blue Cross plan is that BlueAlliance is our version of a value-based program here in North Dakota, but it's certainly not the only one of its kind across the nation. So Blue Cross plans across the nation are doing their own versions of value-based programs and things that maybe work in their markets. And it's great because we can share some of their experiences and learn from maybe what worked in Louisiana or Texas, and maybe it can be applied here in North Dakota. So over 370,000 providers are participating across the nation in some type of value-based programs, and 3 times more than our competitors. But this is certainly a journey that everybody is going on. It's not just the Blue Cross Blue Shield plans that are looking at value-based programs. It is something that the government is trying to figure out. So you see Medicare demonstrations, things of that nature. Everybody's trying to better understand how we can create a better long-term sustainable healthcare system. So let's jump into a few more specifics about how we finance value-based care and how that differs from the fee-for-service world. Primary care providers and the entire care team are at the front lines of value-based programs and really the key to the success of the model. When we look at our data, it is obvious that having a primary care provider results in better care coordination, which is why we encourage all members to engage with a PCP. They can identify care gaps and address the needs of the whole person. We compensate those providers that achieve quality goals through what we call care management payments. The attribution of a member to a primary care provider assigns accountability to that provider to ensure that members receive the right care at the right time. This provides the foundation of the BlueAlliance program. Primary care providers across the state can participate in BlueAlliance in one of 3 levels. All 3 levels have the same overlying goals. We want to make sure that members receive the right care at the right time. That is why the quality measures throughout each of these levels are the same. They are still concentrating on things like keeping people out of the emergency room or keeping people out of the hospital, those well child visits, some of the other quality metrics that we discussed in previous slides. All of those are the same throughout all 3 models. What we start to introduce in levels 2 and level 3 is a per member per month target in which the provider's performance is measured against, and we'll get into more details on subsequent slides. The graph to the right shows you provider participation as of 12/31 of 2019. So the majority of providers are in a patient-centered medical home model. So that is the provider count. But when you look at membership and who's attributed to those providers, actually, we have the majority of our members in a risk-sharing model. So there's only a few providers in that particular model, but it's our larger providers that are in there, as well as the shared savings model. There's a good chunk of membership also in there. So by far, the majority of the membership is involved in a shared savings model or a risk-sharing model. As we move away from the fee-for-service world that incentivizes volume, as Mike discussed in the opening slides, we're transitioning more dollars away from that fee-for-service world and putting it into these two provider payment buckets. So we have care management payments as well as shared savings payments. So from a care management standpoint, this is the payment that's paid throughout all three levels of the program that we just discussed. It supports care coordination for positive health outcomes. All levels receive this payment, and it's adjusted for provider quality ratings. On the shared savings side, this really only applies to level 2 and level 3 of the program. And so that's computed based on the provider's actual costs compared to a risk-adjusted cost target. And it's adjusted for patient risk as well as provider quality rating. We'll get into more detail on subsequent slides. As we transition to value, you should see less than expected claim costs. Those less than expected claim costs are really because of two different factors. We are no longer making as significant as usual fee schedule increases to our providers, so your overall claim costs throughout the year should be lower. Beyond the lower cost per claim, we also see providers providing care coordination, which could result and has across our entire book of business in less claims than we would expect. Because we are not increasing our fee schedules to providers at rates that we have historically, and the improvements we've seen in care coordination, we are shifting those dollars that you would have otherwise paid in claims costs into that shared savings bucket. That's where providers must achieve outcomes and must meet their quality goals in order to receive those dollars. Instead of just doing more, they have to focus on outcomes. So let's show you how the math works. In this particular illustration, we have 20,000 attributed members to a level 2 provider. Level 2 providers can earn up to 40% of the shared savings pool. So let's get into the specifics. In step 1, we look at an expected cost target. This is really a reflection of if we hadn't done anything, we would have increased the fee schedule at the rate that we would have done historically. But the other factor in this expected cost target is also the fact that we risk adjust it. So we know that healthy members cost less than those members with chronic diseases, typically. So we take that into account. So that $534.64 per attributed member per month is a reflection of if we had increased the fee schedule as we have historically done, and really the risk associated with those 20,000 members. So that fluctuates on a month-by-month basis as those members may or may not change as we move along. We then take a look at the actual costs that came in for those attributed members. So those 20,000 members had gone to health systems and accessed different parts of the healthcare system. And so when we take a look at the actual cost, in this particular example, it came in at $487.40. So less than we would have expected. Again, a reflection of the fact that we're paying lower costs on a per claim basis, and the improvement in care coordination may have resulted in lower claims overall. So that difference between the $487 and the $534 is what makes up the shared savings pool. So expected minus actual is about $47.24. So as part of the program, what we do with the providers is we share back a portion of that. In this example, the provider achieved great quality results and so had a fantastic score and was able to obtain 40% of that expected savings pool. So the $18.90 is what you're seeing as an employer being charged back to your account, but that is going directly to the provider. The difference, the $28.34, are really a reflection of the fact that you didn't pay the claim costs that you would have throughout the year. So even though you may not see the $28.34, that is a reflection of things that did not happen as a result of what we're doing with the provider community. So that $18.90 is the share back with those providers to really make sure that they're incentivized to continue to provide this type of care to all of our members and really trying to align the incentives to the benefit of everyone. So because your employees see more than just one provider, you may see different payment amounts coming out. So this is really a reflection of the fact that your folks are seeing multiple providers who have different ranges in performance. So as you can see, those particular providers, so let's look at provider number B, their performance was better than provider number A, so that resulted in a higher payment back to that provider. You can see the number of members that are attributed to them and then the reflecting total. We hope that by walking through those illustrations, you understand a little bit more about the why behind what we're trying to accomplish. And we hope that you're on board with this journey with us. But we also know that we have some improvements to make. So on our part, we need to do a better job communicating on a regular basis to you on what payments are going to what providers and when. We also need to make it more predictable and more transparent on how those folks have performed overall. As part of our next steps in our commitment to you, we will be producing reports to show you which payments are going to which providers and their associated performance. We also want to take a look at your performance compared to expected, which is something that we recognize we do from a provider perspective, but we need to do a better job highlighting the value that it brings to you as an employer. So we're committed to working with each and every one of you to make sure that you understand this program and the value it brings to you and your employees.
Thanks for that, Chelsea, and thank you, Mike, for presenting all that great information on the BlueAlliance program. At this point, we're going to open this up for questions. We've had a few questions that have come in initially here when the webinar was going on. We had a few that came in beforehand too that a few of you asked. So we're going to go through those now. I am going to ask that anybody that's listening in still, we have quite a few participants out there. If you look at the questions panel in the GoToWebinar here, you can type those questions in. We'll answer those live here and get to as many of those as we can as we're going through this. I'm going to do a quick sound check here with Chelsea and Mike. Mike and Chelsea, are you both back with me here? I'm going to make sure nobody's on mute. There we go. Mike and Chelsea, do I have you? Hi, Chelsea.
You have Chelsea.
Perfect.
You have Mike.
Hi, Mike. So we're going to go through a few of the questions. Again, I ask that all the participants, this is your opportunity to ask questions about BlueAlliance. So in that questions panel, if you want to go ahead and type those in, we'll get to as many as we can. We have a little bit of time here left for Q&A, so please do those. Also, for everybody on the phone, or on the webinar, just know that this webinar is being recorded, including the question and answer session here. So we will be sending out a follow-up email after the webinar here that will have this as a YouTube link, so you can watch the whole thing again if you need to go through it again. And as well, in that email, you'll see a link to sign up for News from Blue too. So if you're not on our News from Blue email newsletter, please take the time to sign up for that. There's a lot of great information that comes out on that on a regular basis to keep you all in the loop. In addition to that, at the end of this, there will be a survey that goes out. We hope to do these more, going forward to keep you all abreast of any changes that are happening, keep you in the know when it comes to BlueAlliance. So your feedback on that survey is really important, just so we can curate content moving forward that'll most benefit you and keep everybody in the know. So with that, I'm going to tee up the first question for Mike here, and this one comes in and says, what types of reporting will be available to demonstrate the benefit of this program, Mike?
Yeah, thank you, Jason. To verify, you can hear me?
Yep, I can hear you fine, Mike.
Okay, yeah, thank you, and it's a great question. As Chelsea discussed during her portion of the presentation, we intend to over-communicate the performance of BlueAlliance moving forward, and this WebEx today is an example of that. And as Jason alluded to, we plan to do these on a regular rhythm so that we give you updates from a global perspective on how the BlueAlliance program is performing with our provider partners and providing a benefit to our membership. The types of reporting, we've had a couple different prototypes, and we're fairly set now on what the self-funded client reporting capability will look like. So it'll be everything from how many of your members are attributed to a BlueAlliance participating provider, how many are not attributed. We'll show you the type of payments that Chelsea outlined in her portion of the presentation and shared savings that each of your employees would be seeing with and experiencing with those participating providers. That would also show a variance from that expected medical trend on what we call a per member per month basis. So you can see how your members are attributed, but also how the providers are performing and providing quality of care for that membership. But we also think, besides the financials, it's important to show clinical outcomes. And we're working on some of those items as well, but it would be client-specific reporting on things like what is the risk-adjusted medical allowed per member per month cost. And also things like what was the decrease in potentially preventable ER visits over a yearly basis. So that's the type of clinical reporting and financial reporting that we will have available at this time, we believe, on a biannual basis for self-funded clients. So if you want that type of reporting, please reach out to your account manager, and we will start to produce those for you as soon as we possibly can.
Thanks, Mike. I appreciate that. So the next question I'm going to ask is for Chelsea. Is this a mandatory program or is it an optional program, Chelsea?
Yeah, that's a good question. So, I think as we were walking through the presentation, it's apparent that it takes all parties participating to make this work. We're trying to create that more sustainable healthcare financing system long term to keep healthcare affordable. So everybody is in. We don't have any groups that opt out, and that is true across most of the Blue Cross Association as well. Everybody's in. So.
Perfect. Thank you, Chelsea. And we had another one that specifically asked, can groups opt out? And I think you just answered that question. So, so this next one is for Mike. We're getting a few questions on the communications around BlueAlliance. Can you help address how we're communicating around this program?
Yeah, it's a good question. I think I kind of addressed that in my last response. But moving forward, we plan to have ongoing dialogue, be it from WebEx on our YouTube channel, news from Blue, and then specific to client level reporting. We tend to have more robust communication on this systemically moving forward, so that there's no surprises to clients when payments occur. And I will say that we are looking to smooth out our payment rhythm, if you will, as well, moving to more of a monthly and a quarterly structure as compared to a twice a year impact. So hopefully that gives more predictability to payments as they occur. But we want to make sure that you understand if there's payments, it's being done because there's quality of care.
Perfect. Thank you, Mike. This next one is also for you, Mike. Do these payments go towards stop loss?
Sorry, my dog's, of course, on the squeaky toy right at the moment. These payments do go towards stop loss, correct?
Okay.
Chelsea, just one thing that. Oh,
go ahead.
Sorry, I wanted to add on to Mike's comments. So yeah, the payments do go towards stop loss, and Mike was mentioning in his response to the question just before this, moving to a more frequent payment. And so historically, in BlueAlliance and the programs that were before it, we paid twice a year. And so those incurred dates have been in the spring and in the fall. So we're looking at incurred dates, and that's the amount that would go towards stop loss for that particular year. So sometimes there's the performance period span calendar years, but the incurred date is really what drives where it heads towards that stop loss for that year. If
Great.
That helps.
Thanks for the expanded explanation there, Chelsea. This next one is for you, Chelsea. How do you classify if an ER visit is preventable?
Yeah, that's a good question. The key word is preventable. And there's also another word in there that the logic uses, which is potentially preventable. So sometimes it's hard to delineate for sure that something is preventable. So typically what we see fall in this category are things that could have been managed in a primary care setting, which would have avoided that ER visit. But I know Dr. Glasner is on the line too, our Chief Medical Officer. I wonder if Dr. Glasner, if you want to comment a little bit on preventable ER visits and from a clinician standpoint.
I'd be happy to, and thanks for the opportunity, and thanks for everybody for joining today. Just so you guys all know, I've only been with Blue Cross for 6 months, and I was one of those providers receiving incentive payments and value-based payments. And then if you really look at driving quality and value, it does bend the cost curve. So the program does have merit, and just from the global picture, the program is showing value. But from a potentially preventable admission, here's a classic example. You have a patient with migraines and they don't have a primary care provider. They get a migraine, they go to the emergency room, and they get the highest charge for treatment of that migraine. If you can get them established with a primary care provider, even if that primary care provider needs specialty care, if you can get that patient into a regular healthcare visit process, then you can prevent those migraines, and just by getting them on the right prescription, getting them on the right program, identifying the triggers for the migraines, and then they can treat that on an outpatient basis, and they never go to the emergency room at all. That's a potentially preventable admission to the emergency room visit that saves costs for everybody. So getting people into a primary care provider, getting upstream on their chronic medical conditions does lower costs overall going forward.
Great, thanks for that explanation, Dr. Glasner and Chelsea. The next one I'm going to ask is for Chelsea as well. So how long is Blue Cross Blue Shield North Dakota contracted to be in the Blue Alliance program?
Yeah, it's a good question, and I hesitate always to call Blue Alliance a program because it's really a philosophy shift in how we pay for healthcare. So the actual contract that we have with providers is a 3-year contract. So the next one just started in 2020. So we're contracted through the next 3 years. But we do 3-year contracts, but then it continues to evolve. And there's things that we get right and there's things that need to be modified moving forward, which is why we always ask for feedback. Certainly we want feedback from you all as employer groups. But we also get feedback from the provider community, and certainly things change as we move along. And so this is a long-term commitment to change the way that we finance healthcare, but the immediate contracting term is for the next 3 years. But we have been doing it, a version of it, since 2009, as Mike had pointed out.
Perfect, thank you, Chelsea. Mike, if you're still there, I don't know if your dog still has a squeaky toy, but this one's for you. When are your remaining payments going to be withdrawn from our account?
Yeah, so the squeaky toy has been put away, so hopefully that helps. No, it's a good question, and the timing of some of this. So first and foremost, as Chelsea pointed out, value-based payments are just like a claim, if you will, right? So we're paying providers for performance, just like it used to be in the old volume versus value era. So payments have already been made to providers, but we do recognize that in a very unusual circumstance that we're in during a global pandemic, which is affecting the health of your population and likely the financial impact of a pandemic to your population, we have to be more sensitive to when those payments are taken out. So our leadership continues to have discussions on if the remaining 3 payments will be taken, and if so, when that'll occur. But we do want to reiterate that these payments, like Chelsea gave in that $18.90 payment example on one of her previous slides, have already gone out to providers. So more to come, and we, again, intend to over-communicate this so there's no surprises moving forward.
Perfect, thanks for that, Mike. Mike, I believe this next one you could probably take. How soon will we see group-specific data that quantifies the savings?
Yeah, great question. And I think talk to your account manager. We're working internally with our data intelligence teams and tools internally, and we're already producing group-specific reporting, which includes financial distribution to providers and shows also those clinical outcomes like I talked about earlier. So talk to your account manager. We do have some concerns on statistical significance based on the size of the self-funded client. But the best, if we can, if we believe there's validity in the volume of members who are attributed, we can provide that self-funded client reporting.
Perfect. Thank you, Mike. Again, I'm just going to remind everybody that if you have questions, we got a few questions left here in the panel, but once we get through all the questions, we'll probably break. So if you have questions, go ahead and answer or ask them, and I'll try to get them answered live here as we go through this. This next one, I believe, would be for Chelsea. Are all the self-funded groups enrolled in BlueAlliance?
Yeah, so all groups are in BlueAlliance, whether they're fully insured or self-funded. Everybody is in. Good question.
Okay. This next one is probably a little bit of both of you, but I'll start with Mike here. Can you provide the backup documentation to ensure that the cost associated with BlueAlliance being passed on to us was included in the suggested funding levels that you provided to us?
Yeah, that's also a great question. So moving forward, well, yes, we're going to do our best to provide that backup documentation for historic SFL or suggested funding level estimates provided by Blue Cross Blue Shield North Dakota. But moving forward, we're going to make sure we call that out more specifically so it's clearly visible on what we expect the BlueAlliance payments will be. Now, that there can be a variance based on performance of providers or things like a pandemic can affect that. But so we will do our best to provide historic documentation, but moving forward, we want to call that more clearly on the annual renewal documents that all of our self-funded clients receive.
Perfect. Thank you, Mike. Chelsea, I believe this one is for you. This person is they're trying to understand the ROI relative to the overall costs and savings. And their question is, how is Blue Cross Blue Shield of North Dakota charging their self-funded groups relative to the BlueAlliance fees? They say many of the carriers add the cost to the claims that are being processed and then the true up at the end of the year.
Yeah, so I'll try and answer the question. I'm not sure that I'm following it completely, so please feel free to follow up afterwards directly if you would like via email. Or with your account manager, and they can connect you with me. So we went through a number of slides to walk through. So I think that the key element in determining the performance is that expected rate. So looking at a population, we would set an expected rate based on that population's historical claim utilization, the diagnosis codes on the claim, all of that kind of feeds into what we would expect. I had mentioned that, we would expect healthier folks to cost less, and we expect those with multiple chronic diseases to cost more. So that is all factored in addition to their historical utilization patterns. So if they're using the ER more frequently, then that would be factored into that expected rate, but also any inflation increases. So we've talked about a few times the fee schedule increases that we've historically done have been at a higher rate than what we've done recently. So that expected rate also takes into account fee schedule increases and changes in utilization patterns. And so when we look at actual costs, comparatively, that split between expected and actual is what generates that savings pool. And we pay back just a portion of that to the provider community for the work that they're doing to better coordinate care. And also in recognition that they're receiving less of an increase on their fee schedules, which again incentivizes volume. And so it's a recognition that they've done good work. We're slowing down what would be seen as kind of a guarantee from a fee schedule increase and shifting it into the bucket that aligns everybody's goals and objectives together. And so that difference, that resulting difference on that one slide showing you kind of that employer group savings, that's based on the performance at a provider level. So part of what we're working on is we looking at it from an employer group perspective. So what were the expected costs of that employer group? And that gets into kind of what Mike was talking about with, making sure that we have enough volume within the employer group for it to be statistically relevant as well. But then what actually happened, both from a utilization standpoint as well. So I think I'm answering the question, but it's it's certainly warrants itself to be a one-on-one conversation too, if folks are agreeable to that. There's a lot of detail underneath that expected calculation that if folks want to better understand that, I'm more than willing to spend more time.
Thanks for that, Chelsea. So we got a kudos for you guys. You've done a great job explaining the program, but they would like a bit of an explanation as to the additional billing costs that were pulled over a couple of weeks.
Yeah, Jason, this is Mike. So that was what we discussed earlier. So unfortunately, the math and the finance is complicated. So those billings were really for an effective period of, I believe, July 2018 through June of 2019, I believe is the date frame. So again, those are payments that went off to providers, but as all things with healthcare, the math takes some time and it's far from real time or near time. So sometimes that math and the performance of that provider takes longer to prove in effect. So there was payments, those first two payments in May that we discussed earlier. The last three have been held for now, and that's what I alluded to when I talked with leadership at Blue Cross Blue Shield North Dakota, is still digesting on if, but likely when would those payments come out yet in 2020, just due to the fact, again, that the providers have been paid for these performances for the quality of care that they've provided. But Chelsea, I don't know if there's anything you want to add to that comment.
Sure. I think that we kind of outlined those 5 payments in the email that you all would have received prior to the funds being pulled from the account. So as Mike mentioned, that performance period is 7/1 of 18 through 6/30 of 19. All the incurred dates are in 2019 for those 5 payments. And that follows what we have done historically with, I'd mentioned the incurred date being twice per year in the spring and in the fall. And so this aligns with that. So even though the performance dates span 2 different years, that has happened since the program's inception, and the incurred dates typically are in that year of which it ends, that performance date ends. So
yeah, and Chelsea, this is Mike. I would add to the 2. So we know that was surprising to a lot of employer groups. For some employer groups, we have the opportunity to get in front of frequently. We feel like there's less surprises, but again, we want to over communicate on how BlueAlliance payments are going to occur moving forward. And again, remember, these are payments to providers, not to Blue Cross Blue Shield financial reserves. So we're going to try and over communicate that moving forward. Traditionally, BlueAlliance fees have been less than 4% of a typical self-funded client spend. That's not saying 4% is a small number, but it has been a relatively small portion of claims expense. However, that's part of why we want to start over communicating, because these numbers are just going to continue to go up. Because as we suppress down fee for service, as we suppress down that fee schedule, value-based payments will go up. So we want to try and do our very best to make sure there's no surprises, that people understand what they're paying for from what they used to pay for in a fee for service environment.
Thanks, Mike and Chelsea. I'm going to kind of do a last call since we're getting close to ending here on questions, because we're probably going to get through these, but it might be kind of tight. So if you don't have any more questions, that's great. But if you do, we could probably take a few more here, and then we're going to be running at times. So this next question here is probably for Mike. Are payments for these savings based on the activity of our members, or is it the same charge for every member in all groups?
Yeah, great question. And as Chelsea tried to and did show in her example that in the client-specific reporting, we'll show you this. You'll have different providers or different members who are seeing different providers, and you'll see how many are seeing those providers who are participating in our BlueAlliance program. And as Chelsea discussed, there's over 90% of our providers who are participating. But each of those providers' specific performance on quality will vary in the charge. So that's what we'll try, and that's what we will show in the client-specific reporting. So you can have variance based on how many members are attributed to provider letter A versus provider letter B. So there'll be a variance, but it's based on the particular quality performance of those providers, and then your attribution methodology will affect that payment. But Chelsea, anything to add to that?
Nope, I think you covered that pretty good.
Great. So Mike, I'll pose this one to you. If these payments go to stop loss, how does this work with such a delay in the final determination of the program assessments?
Yeah, another good question. Chelsea, I'd actually punt this one to you. Any particular thoughts on incurred date with the delay in the quality performance score on stop loss?
Yeah, so the payments that have been distributed here in 2020 and the first part here are in line with what we've done in the past. So all the incurred dates are in 2019. So we've experienced this before and attributing it back to, it counting towards stop loss. If you think about it from a claim perspective, we have a timely filing rule of 12 months from the incurred date. And so that's, you could see on a claims basis, you can see payments much later. And our goal is definitely to speed these up, as Mike had mentioned. We want to do, monthly care management and up to quarterly for the shared savings distribution so that we can keep it more real time. What we've done historically is wait until the entire performance period is over, and then we look for 3 months of run out to make sure we're capturing as many claims as we can, and then we'll do the comparison between expected and actual. So it does get delayed, but the goal is to move it up. But I would just make that comparison to a claim cost. We certainly see situations where we see claims come through well after the fact. So it's going to operate a lot in the same manner that would. Mike, is there anything you want to add to that?
No, I think you're spot on. To me, to some degree, I almost feel like this is going to be a weird tangent or a pivot, but almost like rebates. As we settle on the quality of performance of the providers, just like a self-funded client would receive pharmaceutical rebates, it takes time for that settlement. So the payments for those used to be 18 months. Now we're progressed to 10 or 12 months. So it's complicated math. And again, our goal is to be as transparent as possible as it can, but there is just a lag to understand and really evaluate the provider performance on quality.
Perfect. Thank you, guys. Mike, I'm going to ask this one of you. What are our members receiving as far as direction to utilize primary care physicians so we can realize the savings you're describing?
Yeah, that's a great question, and that's actually the heart of the program. So first and foremost, we think the most important thing in healthcare is making sure that members have a relationship with their primary care physician. So we try and work with self-funded clients, and if there's additional communication materials that any self-funded client wants, we're happy to partner with. We already have items or communication materials that are developed. Things like, if you see a PCP, this is what it costs you. If you go to urgent care or walk-in clinic, this is what it costs you. If you go to ER, this is what it costs you. So really making sure we're driving to the most conservative but high quality channel of care, which would be the primary care physicians. So reach out to your account manager. We have already developed communication materials on that, and we're happy to develop something that would be specific and customized to that particular self-funding employer group.
Thanks for that, Mike. Chelsea, I believe this one would be for you. Going forward, is the BlueAlliance cost included in the claim cost from a billing standpoint, or will clients see additional billings for the cost of the program?
Yeah, that's a good question. So it doesn't flow through in the way that a claim would flow through, but it's part of the claim cost, if that makes sense. So you'll see a separate line item under value-based, like you have for these most recent payments. So there'll be, we're going to aggregate it. So again, to be transparent on what's associated with the value-based program, you'll see that, but it does roll up. It is part of the claim cost. It's just split out differently from your claims. So historically, we used to send it through on claims. So you would see if you have, 500 attributed members, you would see 500 claims with the same incurred date. And so we're just aggregating it and showing you what the total is across your group, but it is part of the claim cost.
Perfect. Thank you, Chelsea. This next one is also for you, Chelsea. Can one provider participate in all three models that you described, like the patient-centered, the shared savings, and the risk sharing?
Yeah, good question. Each of those levels kind of build on one another, so they pick which level they want to be in, but there's elements that are consistent throughout. So the quality measures are going to be consistent throughout all three levels. Right now, this year, the majority of the providers have kind of landed in a level 2 arrangement, so a shared savings. So it's consistent with the example that we covered, where they can earn up to 40% of the shared savings. So yeah, they pick one, but there's common themes throughout all of them.
Perfect. So Chelsea, I believe this one would be for you as well. Are you saying that 100% of the amounts pulled from our account for BlueAlliance goes directly to doctors and 0 is kept by Blue Cross Blue Shield of North Dakota?
That is correct. So everything that is being charged back to an employer has gone directly to the provider community.
Perfect. Thank you. And then Chelsea, I'll ask this one of you as well. It's a little longer question and there's an example, but I'll try to restate it here. Can you briefly explain once again how a provider is incentivized to accept only a portion of a potential claims instead of a greater payment by pushing more services?
Yeah, it's a good question. So it really kind of gets at the whole transition to value piece. So why would providers participate in a value-based program? Why wouldn't they stick with like a fee schedule guaranteed amount? And the answer is we're not increasing our fee schedule at the rates that we had before, regardless if you're participating in the program. So if you want to earn a portion of those dollars that you would have otherwise seen in a normal like fee schedule increase, you need to participate in the program, which is why we have great participation within the program. And I think there's a recognition amongst the provider community that we need to do something different to finance healthcare. And so operating in that fee-for-service world just isn't going to create something sustainable long-term. That's why you see more and more providers partner on Medicare demonstration projects and get involved in other value-based programs with other payers. There's that recognition that the fee schedule increases of years past have kind of shifted into this value bucket where we need to achieve outcomes. And so there's that piece. And I don't know, Dr. Glassner, if you want to comment at all on kind of this whole transition to value and why providers would want to engage in that world.
Sure, I'll be happy to. There's a couple reasons. Number one, I think the provider community recognizes that the fee-for-service model is breaking. I mean, you just can't keep raising rates to the cost of the members. And then on the second part, if you're trying to be in one of these large groups or a small group and you're paid on a fee for service basis, in order to even maintain your same operating model or operating income, you have to actually just see more and more every year. And there's a point where you just can't see one more patient per day per provider in the clinics. It becomes an unsustainable formula. So you have to look to provide care in a different way. If you can provide value, you get paid for value instead of volume, it's better for the patient, it's better for the operations, and it will save money long term going forward.
Perfect. Thank you, guys. With that, we've reached the end of the questions, and I'm going to probably conclude the webinar here shortly. I do ask that all of you that are listening in, thanks for joining us today. And I'd like to thank Chelsea, Mike, and Dr. Glasner for sharing this information on the Blue Alliance. In addition to that, you will be receiving a follow-up email here. So if you are not subscribed to News from Blue, please do that just to stay in the loop with current updates as we communicate this going forward. In addition to that, this will be available on a YouTube link. So in that follow-up email, if you missed anything or want to review it, please follow that link and you'll be able to watch the entirety of this webinar along with the Q&A section of it on YouTube. And lastly, there will be a survey that will pop up when you leave the webinar today. And I just ask that all of you provide us a little feedback on the quality and the content of the webinar so we can provide good content going forward and try to explain this to you as much as possible. So with that, I hope everybody has a great afternoon and thank you for joining us today. Goodbye, everybody.